Hello, my name is Sarah Waya, a clinical lecturer in prosthodontics, and today we're going to talk about intraoral scanning and scanners in dentistry. So we start any presentation with the definition and the general definition of intraoral scanners. They are devices used to create optical impressions to record the three-dimensional morphology of teeth and their surrounding tissues. So they basically project a light source on the dental arch. The image captured by imaging sensors is then processed by the scanning software, which generates point clouds. There are so many advantages of using intraoral scanning or digital impressions. So basically, it reduces patients' discomfort, and so many patients have different problems with conventional impressions. Some may have severe gag reflux, and this will be quite helpful in those types of patients. It's also time efficient, and I put 2 stars next to time efficient because there is a learning curve in using intraoral scanners. We need practice, and different models will have different we'll need different time for scanning. They will also eliminate plaster models, which is a huge advantage, because then we won't need the storage space to store these plaster models. You will have easier communication with the lab, and also easier communications with patients. You can show them how you anticipate the treatment will go. You can show them a post-op idea or a diagnostic wax-up on a digital wax-up, and it's helpful in severely mobile teeth. Okay, so I'm gonna show a case now, which I actually was referred to me by general dentist for planning and treatment. So this patient, she has acquired tooth loss and tooth surface loss and periodontally compromised teeth. So she has grade 3 mobile teeth, especially on the lower anterior area, as you can see on the radiograph, vertical and horizontal severe bone loss. So before we need primary impressions for treatment and planning. So before taking primary impressions, we should consent the patient for extraction, because it's highly possible that the lower teeth will go out with the impression. Okay, so we need to consent, we need to provide local anesthetic just in case that happens. The second way is we put a splint on the teeth temporarily before taking the impression. And the third and best way in cases like this is to use a digital or intraoral scanner. Times in prosthodontics, we need to use different ways to establish a 3-point contact or a stable jaw registration, whether we're planning or we're taking definitive impressions. So for example, in this case, we can take this jaw registration 2 ways. Okay, we can either use an acrylic or wax base with wax rims, as you can see on the top right photograph, or we can use jaw registration silicone, and I use the combination Futar D and putty in the lower right photograph. So if we use an intraoral scanner, we would eliminate this step. We would actually only ask the patient to bite, and we would scan the way he bites directly. Now let's talk about the limitations of intraoral scanners. It's still difficult to detect margin lines in case of bleeding if the crown preparation is subgingival. There is a learning curve in using scanners, and there is differences between types and brands of scanners. They are costly, and they're not adequately accurate for long span bridges, so we're still doing research on that. Now, unlike conventional impressions, it's difficult for the light to detect subgingival finish lines. So the same as conventional impressions, we can physically detach the gum using either a traction cord or electrosurgery or different techniques, but with the light, it's difficult to do that. So we have to still use conventional retraction techniques while using the intraoral scanning if the finish line is subgingival. So I'll show you a few cases. This is a case where I physically retracted tissues using a double cord technique and an astringent as well. So as you can see, good retraction will achieve good impression, clear margins, and it will provide you with a good well-fitting crown. This is another case where I used actually a combination of electrosurgery and retraction cord to record the gingival margin. And as you can see on the right side, now you can see the margin fully, while it was difficult to see in the middle photograph. I'll talk about another technique, or what we call a hybrid approach, in using lab scanning plus conventional impressions. So imagine, this is we do normally in our hospital actually. So we take a conventional impression, for example using alginate or silicone, we pour it, we have a study model on the left hand side, and then we go to the lab and we scan that cast using our lab scanner, and what we have is the dental wings lab scanner, and we can actually we digitize the model or the cast, as you can see on the right side, okay, and then we have an STL file or a digital file of the model. This hybrid approach will help you if you wanted to do a digital diagnostic wax up instead of a conventional one. For example, on this slide on the right, I used a program called, or a software called Mesh Mixer, to add a lower 5, and here I was planning to place an implant. You will learn more about the digital workflow when you take the implant module next year. Now let's discuss how do you determine whether a scanner or an intraoral scanner is accurate enough. Accuracy is the sum of two things. It's the sum of trueness and precision. So the definition of trueness is the deviation of the impression geometry from the original geometry, while precision is the deviation between repeated impressions rather than to the original geometry. So both these definitions, they will help with research and research on scanners, accuracy, precision, and trueness. Okay, so why is trueness important? It's important for the fit of dental final restorations, because we're actually assessing how deviated the impression is from reality, while precision matters because the scanner will be used with by different people, different clinicians, or it will be used by the same clinician at different times, so we want it to be consistent. So I took this figure from the book Extracoronal Restorations, and it clearly explains the difference between trueness and precision. On the left hand side, you can see good trueness but poor precision, while on the right hand side you can see good precision, meaning all the scans are close together, they had different results, but however they are not true, because trueness is actually in the middle and the scans we took are far from the middle, from the actual true geometry. Now, how to calculate trueness and precision, and this is important to know for research purposes or when you're reading articles on the accuracy of fit or the accuracy of scanners, you will read these terms a lot, trueness and precision. So to measure trueness, we will overlap a scan with a reference scan. So imagine you want to evaluate a specific brand of a scanner. You would get a reference scan using an industrial optical scanner, which we know they're accurate, okay? And then we use the intraoral scanner and superimpose both and evaluate the difference. This is to calculate trueness. While to calculate precision, it's actually easier to calculate. It's simply done by overlapping different scans with the same intraoral scanner at different times, and then we evaluate the difference. And I'm going to discuss a research that used this technique. Now let's discuss the current evidence. There are lots of articles on scanners and accuracy. I only chose two for the purpose of this lecture, one in vitro study and one in vivo or clinical study. So this in vitro study, they used digital scanning to measure and compare trueness. And now we know the definition of trueness and how to measure trueness. So they used a master cast, which was digitized, and 10 so they used 10 impressions, digital impressions, and 10 conventional impressions, and they superimposed them to compare trueness. The results show that dental implant impressions had similar accuracy as conventional implant impressions. Now, of course, we approach these results with caution because it's an in vitro study and we always need to verify it using a clinical study. The second paper I wanted to discuss is a clinical study which was done on 5 participants. The aim was to assess the precision of digital and conventional complete arch impressions. And here they assessed the precision, so we know what they did. They took multiple scans, either by different people or by the same clinician at different times, of the same thing. And they superimposed them and checked the deviation. Okay, on the right hand side on the figure, it shows the different typical deviation pattern between repeated complete arch scans. So the colors actually are the deviation, so it's the color grade. So minus 100 micrometer is purple, plus 100 is red. Any deviation over 100 micrometer can lead to ill-fitting definitive restorations. What we conclude, or what they concluded in this article, is that conventional impressions actually showed higher precision than current digital impression systems. Also, again, we approached the study with caution because it was a clinical study done only on 5 participants, so it's not a huge amount of data. These are the references that I used in this lecture. So the first two are the in vitro and in vivo study, and the third one is the book, which has lots of digital techniques, digital impressions, and how to select materials. Very useful to look at. So I'm going to attach a link to the scanner we use in our hospital. I hope you'll find it useful, and we will try it in clinic next time. Please don't hesitate to email me if you have any questions or ask me